And we of course have with us none other than Sunita Tandulwadkar ma'am, the president of Fogsi, who gives us all the opportunities always to conduct such wonderful podcasts. And this, in fact, is the 234th edition. I somehow have been lucky with the different episodes, etc., that we have done. And today the number is 2, 3, and 4. So again, a wonderful number that we are having today. And we are going to talk today on PCOS, the new endemic. And I first of all would like to welcome our enigmatic president who is omnipresent, none other than Dr. Sunita Tandulwadkar ma'am, to kindly give us a welcome. And then we will go ahead with this session with Dr. Uday Tanawala, sir.
Thank you, Priyankur. Thank you. You all chairpersons, Uday, welcome to this Foxy platform on Star Podcast Pravaha series. And believe me, 234 day, every day, 8 p.m. sharp, we start. I always join to show the respect that the faculty get into Foxy platform. They give their time, they give their valuable inputs. Sometimes we have a gynecologist, but sometimes we have a non-academic or the experts from other field of surgery, neuro, and other things. We had politician, philosophical leaders, spiritual. It's beautiful global networking we are doing. When we started and when we decided the same day. So today, if it is a 19th, Priyankur will be there on 19th of every month. So I have a 30 committee chairperson. They have been given 30 days, 30 podcast. And believe me, everyone, because these are the future leaders of Foxy. And I feel they should get a platform where they can showcase their creativity, talent, their leadership skill, and they may learn these skills more as they grow. I'm very sure what Priyankur was in the month of February and what today he is in his thinking, in his the way he will take the interviews, discussion ahead is going to be, and we are looking forward for this chairperson to become president one day. They will lead the organization in different way. So they will always remember this podcast when they have started in their young age. And I'm so thankful to you, Uday, for coming and being with us on a Foxy platform today. The platform is shared only by two people, the chairperson and the faculty. I always join the viewer links and I will be watching both of you from there so that my chairperson get undivided attention by the country. So thank you so much and enjoy your podcast. Thank you.
Thank you,
Thank
Sunita.
you so much.
Wonderful, and you've taken so many initiative, and this is one of your very unique ones, which I must say is a
Yeah.
very unique initiative every day to engage and into some activity. So, well, hats off to you for all the work, good work you are doing, and your all the effort which you are putting in, like making it sure to join is also an effort and wonderful. And I know how your practice is. So, with all that, you are handling your
Yes.
presidency very, very well. All congratulations and
Thank you.
hats off.
Love you.
Yeah.
Love you
Absolutely.
and
Uh,
enjoy this. And it's really honor, not because he's a ICOG past chairperson or anything, but he's my great friend. And that's why I'm so glad that you got him here.
Thank
Thank
you
you.
so much, ma'am.
Thank
Absolutely, as Uday
thanks.
sir said, I would like to reiterate the words. I mean, we've got so much of opportunities. We learned so much from Sunita ma'am this year, and we are lucky enough also in the next couple of years, as her being the ISAR president, we're going to continue learning from her as well. So thank you, ma'am, for always giving us
Thank you.
opportunities. It's a pleasure
Thank
to
you.
have you, ma'am. Thank you so
Thank you.
much.
Bye.
Uday sir, thank you so much for joining us, sir. So we are going to discuss on this topic of PCOS, the enigmatic disease. And first of all, to welcome you, to introduce you to the audience who's present over here. I'm sure you don't need any introduction, but just to formally introduce you, he has been the past chair of the Indian College of Obstetrics and Gynecology, past vice president of Foxy, and as well as he is currently the treasurer of the PCOS Society of India. This being the PCOS Awareness Month, we definitely wanted someone from the PCOS Society of India, and who better than Dr. Uday Tanawala, sir, who will be representing PCOS Society in this program today in this podcast. Welcome, sir. Thank you so much for joining us, and thank you for finding time in spite of your busy schedule.
Thank you so much, Priyankar, for having me here. It's wonderful. And I don't know. I mean, PCOS is such an enigmatic topic. I don't know how much I'll be able to uh, throw more light on it because it's been talked about so much everywhere, every place. and today the patients themselves are also so aware about the PCOS. But I think it's a nice topic to discuss and talk about as a to and fro dialogue. So I think let's get ahead with that.
Absolutely, sir. So, sir, to get the balls rolling, we all know that PCOS is one of the most common endocrine metabolic disorders in women of the reproductive age. But I want to know from you, sir, do you feel that PCOS only is limited to the reproductive age, or is it the adolescents? Is it the menopausal, perimenopausal, and menopausal ladies who also sometimes get affected by PC?
No. PCOS is a syndrome which is manifested in women, and if it is there, it just doesn't go away. What you must understand is that if a woman is diagnosed with a PCOS, even in her reproductive age, and that she's told she's a PCOS, some people come and tell me that
Uday, sir, sorry to interrupt.
PCOS.
Sorry to interrupt. Can I request you to increase your volume a little bit? It's a lot. It's a bit low, sir. If you could just
Is
check
it
on that
better
one.
now?
A little better. If you could just increase the volume a little bit, sir. Volume.
My volume is at the maximum.
Yeah, sure, sure. It's better now, sir. It's better now.
So I'll probably be closer to the laptop then.
Sir.
So is it better now?
Yeah, it's much better. Much better, sir.
Do you want me to put on earphones?
No, this is fine, sir. You can go ahead, sir.
So women sometimes come and tell me that we were diagnosed as PCOS, like abhi wo problem nahi hai because they've delivered their children and whatever. But we must remember PCOS is a disease which doesn't go away. It has to be only kept under control, and that's what I tell all my patients who are diagnosed as PCOS. Because in the perimenopausal and menopausal age group, they are faced with much more problems than a regular woman because they are more prone to diseases like diabetes. They are more prone to problems like hyperandrogenism and hyperlipidemia. So they have all these disturbances because they had PCOS and they still have PCOS, though it may not be manifesting as a problem to them at the perimenopausal and menopausal age group. But we have to be careful, especially because of irregular periods. When they get delayed periods, they sometimes take it lightly, and these are the women with an abnormal sugar. So the chances of going into endometrial hyperplasia and endometrial cancer is very high in this group of women, and they have to be careful throughout life. Any patient with a PCOS, she has to be counseled that for you, lifestyle change is the most important thing which you have to do. You have to do regular exercise and always be aware of what you are eating and control your diet if you want to keep your PCOS under control. That is one
Absolutely.
thing which goes in all ages.
Absolutely. I think that's the perfect message to give in because that's the important point that I wanted to discuss with you, sir, to bring it out from your mouth that that in PCO it's a disease. Once it's set in, it's there forever. So it's like we recently had this CME of the E3 series which PCOS Society of India does, and we were very
Yes.
happy to have Durusha ma'am in Siliguri as well when she was doing the program, and she said that PCOS, as you said very rightly, that she said that PCOS is a disease which is from, rather we can say, from the womb to the tomb. So it starts right from the beginning and
True.
you carry it throughout your entire life. So that is the very important thing that you said, sir. So of course, when that sort of a scenario we are talking of, we know that as gynecologists, we will probably have to give a comprehensive care to the patient, which is more towards a little bit towards holistic and comprehensive sort of a care. So do you what are the routine sort of recommendations to tips and bits of comprehensive care that you would go, would like to put forward to the gynecologists who are listening to this podcast?
Priyanka, if I can digress a little, since you got Dr. Dhurusha, who is the president of our PCO Society of India. She started the society 10 years back, and she's doing so much of work, and she has so much of thing. And one of the things which she now is, we have to give a slight importance that it's not only women who suffer from PCOS, it is even men who may have a syndrome like they get alopecia, hyperandrogenism, and all that. So she has a beautiful lecture on does PCOS occur in men? So you should
Men,
listen to it sometime.
absolutely.
So anyway, I'll come back to your point. We will forget the men for the moment. We will concentrate on
But we
women
will come back to
since
the
we are
men. So I have that in
gynecologists.
the list of questions that I
So
want to ask you.
your question was
Comprehensive care.
what advice to be given
Yes,
as far as
comprehensive care and holistic approach. Yes, sir. Sorry, sir, we lost you in between. I can see you, sir.
What?
So
Yeah, I
was that,
suddenly got cut off, but my Wi-Fi.
I think, was it some signal issue, sir? I don't know,
Yeah.
sir. Please go ahead, sir. No problem.
Oh, my Wi-Fi is very strong here. There's no problem.
I'm not sure, sir. There is a little bit of a lag as well
Is
that
it
I see,
okay
sir, when
now?
you are
Can you hear
talking.
me?
I can see you, sir. I can hear you as well, but there's a little bit of a lag, sir. So I think it's okay, sir. We can go ahead, sir.
Okay, so you are asking me about what lifestyle, what
Comprehensive care
message
and
we give to
holistic.
the patients when they come
Yes,
to us.
yes, yes.
See, Priyanka, this is a very, very big group which you are asking me. When you say about comprehensive care, we have to treat them for the primary complaints they have come to us for. Okay, now if an adolescent girl has come or with a young woman with only period disturbance, we have to address that. If a woman has come with infertility or delayed periods, we address that. But I think I will switch over to my phone for the internet. Is it still unstable?
It's a bit unstable, sir. There's a lag that is present, sir.
Okay, do you have me now?
Yeah, clear, sir.
Okay, it's better, right?
Better. Definitely better, sir.
Okay, so when you're talking about comprehensive care, in addition to the problems they've come for, every PCOS woman whom we diagnose as PCOS has to be stressed upon the importance of lifestyle change. And that simple thing is that you need to get some physical activity every day, and you need to have proper diet. Now, it's very important. Now, just the other day, we had an adolescent girl who came to me, not an adolescent, maybe she was 19 or 20. And when I told her that, listen, you need to fill up your bladder so that I can do a sonography, she immediately turns to her mother and says, oh, I think I'll have one Coke and fill up the bladder. So, that is when I had to sort of say that, okay, listen, now you must know what are the good foods and what are the bad foods
Yeah.
and what you should avoid and what is junk food. And then with that, there is no physical activity today because the children are so busy in their studies, their regular schedule is so tight that physical activity is becomes a big problem. So unless we as clinicians draw their attention to this part, that a junk food is a no. You have to just stop it and then meet a dietitian and get on a proper diet. That is number one. But avoid junk food is one message which we all can give. And secondly, what I try to explain to them is PCOS is all about insulin resistance. And besides drugs, or rather with drugs, musculoskeletal exercise reduces the insulin resistance, and that will help you in getting treated rather than the drugs, and much more effectively than drugs and much more permanently. So you have to tell them it is your body, you need to find time for your body and do it yourself. Now, whether you do it in the middle of the night or early morning or in the afternoon or in the office or whatever is up to you, but you need to pick up some physical activity which you think you can stick with. There's no one physical activity. If you like dancing, do dancing. If you like cycling, do cycling. If you like swimming, do swimming. So some sort of physical activity needs to be done by every woman, and this is also important in the group which you were asking me about, the perimenopausal age group, because that's when they want to do musculoskeletal exercise to improve their bone health. So everything today, everybody must get that thing that diet is extremely important, and
Absolutely.
we have to have some physical activity to treat this particular disorder in addition to
Absolutely.
whatever complaints they've come with.
Perfect, sir. So I think the important message, yes, to the comprehensive holistic care, diet, as well as physical activity is something that we definitely look forward to. Perfect, sir. So you talked a lot of mentioned that adolescent girl who came to you. She you said to fill the bladder to do an ultrasound. But sir, in adolescence, how easy is it to diagnose PCOS? And second part of the question would be, how easy is it to counsel them and their parents that this girl is having PCOS, so that they can take it forward for a better life, so that it's under control.
So when you talk about adolescent, we are talking about a very young girl, like within 8 years of menarche, we generally would not even put the diagnosis of PCOS. But if she's come to me with symptoms like, okay, she has a little bit of extra hair growth, she's got irregular periods, she's obese, then I'll put her as something as at risk for PCOS, not PCOS. In adolescence, we never sort of give the diagnosis of PCOS. The diagnosis of PCOS starts after 8 years of menarche, and then you see how her cycles are, how many cycles she's getting in a year, and then you sort of tell that whether she's got PCOS or whether you label her as a PCOS or no. Before that, in an adolescent girl, I may have a girl who's on sonography. Most of these adolescent girls have a multicystic ovary because that is how the ovary appears in an adolescent girl. So that is no criteria. We don't advise AMH as a criteria in adolescent girls. So adolescent girls, only thing is that okay, look, if you don't change your lifestyle now, you are at risk of getting PCOS. So that's one group of adolescent girls whom you feel कि अरे इसको तो आगे जाके problem हो सकती है. It is better to tell them that you are at risk of PCOS and keep them under observation, but give them this advice of physical activity, of avoid having a proper diet, of getting to their proper BMI. Weight is a very sensitive issue now. I've had patients who were offended when I asked them to step on the weighing machine. So, you have to actually tell the patient, do you mind if I take your weight? It has come to that. That is the way the patients want to be treated today. So you have to tell her that, please take your weight and let's calculate your BMI and let us see if this is healthy for you or no, because that is the way it is. If the BMI is high, you can easily tell her that this the ideal BMI in Indian conditions is 23. If you are 27 or you are 30, you need to get back by losing so much weight. But after that, even if you lose 10% of that weight, you will see a difference in your symptoms. So that is what strikes them, that losing a bit of weight will probably help them. And I've had women who have lost weight and they've found such a remarkable difference in whatever symptoms they have, that it is that they follow the advice then very properly.
Sure, sure, perfect, sir. So I think it's you're making my job a lot easier today, because where you're ending, I'm sort of I'm like, the next question that I want to ask you is exactly where you're bringing me to. So it's becoming so much easier, because you told us about the adolescents. You talked about the dietary things and etc. So and also, of course, obesity etc. is a component, definitely, but we have definitely a component which is called the lean PCO as well. So,
Yeah.
sir, though we don't see lean PCO much in the maybe in the adolescent age group, but lean PCO is a component which we all agree is a little difficult to probably diagnose, and a little difficult to manage as well. So, sir, what is your take on lean PCO? How do you diagnose them, and what counseling points helps you in managing this lean PCOs?
See, for diagnosis anyway, it is the Rotterdam's criteria which we go by, where it's not a question of weight. It is whether she has a ovulatory dysfunction, whether she's got hyperandrogenism, and whether she has got a polycystic ovarian morphology on ultrasonography. So these three criteria are there for the Rotterdam, and any two being present, we anyway diagnose them as a PCOS. So weight it comes later because we know that obese PCOS are difficult to manage unless they lose weight. Now, when it comes to a lean PCOS, it is that thin Indian concept, where there is a fat around the liver and there is a fat around in the viscera. The visceral fat is there, but not so much on the body mass. So you have this lean PCOS who has polycystic ovaries and has same either hyperandrogenism or oligo or ovulatory dysfunction, or difficult to become pregnant. So they are definitely to be treated just like a PCOS. You have to tell them that, okay, even if you're weight, it's not a question of weight. You need to be physically active because that is going to help your hormones to come back into alignment and help you to ovulate, etc. So they have to be treated like a PCOS. Dietary restrictions, you have to give them a high protein diet and tell them to avoid the fats and all anyway. And the moral is the same treatment, but we don't measure the weight loss in them. That's a different thing.
Absolutely. Perfect, sir. So the lean PCO, I think that's a message that you give forward, and the management is almost similar. We need to understand about probably the weight loss is not something that we talk about, but rest of it is more or less similar that we probably do in this ladies and this girls or women as well. So lifestyle modification you have talked about very vividly. You talked about to us about decreasing the fast food, doing some bit of exercise, etc. So I would like to ask you, what is your take on sleep and stress reduction in PCO? Because nowadays, I think people are talking about that as well. They're talking about stress, sleep, etc., as one of the components that exacerbate PCO. So, what is your take on this, and how do you, would like to, put it forward for everyone, sir?
Okay, so I had, stress is such an important thing which we don't really pay too much attention to, which is sad because there are patients now, this is something common in everybody's practice. You're doing pre-treating the patient for infertility, doing an ovulation induction, period aaya, then they come crying to you. That is when it strikes you, oh God, this woman is really stressed. So, we just try to pacify, okay, it happens, you'll conceive again and all, but we do not go into the uh, actual stress score for these women. So basically, Priyankur, it is something which needs to be addressed in every girl, adolescent, or infertile, or because adolescent girls also they have a lot of stress because of the body image idea which they have. They have hirsutism and they are looking at other girls and they have got pimples and they've got acne, and we as doctors we don't realize because well our practices are busy, we don't have enough time for that, but it is something which now we need to start paying attention to, that every girl who comes to you as a PCOS because of irregular periods or body image etc could have a lot of amount of stress or depression, because depression is very common in PCOS girls. Anxiety is very common in PCOS girls because they're very anxious कि क्या होगा, कैसा दिख रहा है, body image कैसा है. All those things are very important. So what I generally advise in my practice is any girl who comes to me with PCOS and especially with infertility, I follow the WHO well-being score of 5, which is there on the net, or it's a very simple score. Uh, I wish I had it here, but there are just 5, 6 questions which everyone answers that I feel good most of the time, some of the time, half of the time, none at all, etc. There are 5 questions like this about the patient's mental well-being. You come down to a score and you calculate it, and if it is very low, that means that this patient needs attention. Sorry, she may she may be actually very depressed or be very anxious, and she may require anti-depression drugs, etc. And some patients require a little bit of psychiatric help or a psychological reference also. So mental health is something which we do not address so much, but we need to focus on that. It's a very important component of treatment also, and it is not easy for a PCOS girl to lose weight because there are hormones which are working and there are different things, and they get very depressed about the whole thing. So depression is a very, very common finding. I think whatever rates were given in the ASHRAE were around 50 to 60% of the girls have depression and anxiety altogether. So mental health is something which we need to focus on, and a simple way of doing it is doing one of these scores which are available, either the WHO Wellbeing 5 Index, which is only 5 questions, or there is some PHQ-7 or something which has a little more detailed questionnaire, and there is even a question on suicidal tendencies because you just don't know how these
How
girls
they will
react.
behave?
I had a this is about 10, 12 years back when I had this girl who used to come for follicular monitoring. She came only once or twice. And then I had the police come to my consulting room after about a year or so. That like this girl has committed suicide, and the parents have filed a case against the husband that they were mentally torturing her. So this is where it is. I never realized because when the girl comes, she's with the husband or the mother-in-law, generally the mother-in-law or the husband keep talking, and the some of the girls of this, they keep quiet, they don't say too much, so you don't even realize how anxious they are. That's when I realized it is important to look at mental health of all these girls, because you don't know what is going on,
What is
and
going on in their mind?
we need to assess it somehow. And that is when I started this in my practice, and I do the WHO well-being score of 5, which I find very easy to do. And
Perfect.
while they are waiting in the consulting or after my consultation, they just tick mark, and then I calculate the score and tell them. So it is important to
Perfect.
look at the mental health and address it. And if they are stressed, I give them some techniques, which I have anyway made into a small booklet. I can show you the booklet.
Yes, sir.
So this is the booklet which I have made on you are too
Oh,
blessed to
perfect.
be stressed, and simple techniques, day-to-day techniques on what they can incorporate in it. Like one simple technique which I can elaborate since we have the time here is that it is what you think happens, what you think manifests. So I say that you and your husband should sit. If you want a baby, you and your husband sit together, hold your hands, close your eyes, and just think as if the baby has come, it's in your house, it's playing with you. How do you do it? So all that is described here. It is got a very nice name, that it's called the 5-minute miracle. So
Lovely.
so I give them this booklet whenever I find the score is lost, because you just don't know. Even if you say, okay, now go and see a psychologist or see a psychotherapist, how many of them will actually go, we don't know. So,
Correct.
but some of them, so you have to stress, and if you think you require mental health, you have to be very straightforward with them and their relatives and tell them that, look, this is one area where you require help also.
Perfect, sir. Perfect. So,
So
sir,
we can do,
in
as
your like,
gynecologists, we can do only limited stuff as far as mental health is concerned. We can do some limited stuff in our own consulting, but in general, if it is more than that you feel the patient requires, you must refer.
perfect. So, sir, I was coming to that. So, in your practice, as per your experience, do you feel these girls with PCO, especially the adolescent PCO, going to school, pimples, lot of hair, etc., they require more of like, because of depression, some bit of psychological help? Or do you more often in today's context refer them to any cosmetic clinic where they for hair removal, etc.? Which do you find is something that trend in today's day these young girls are switching to?
It would depend on what the patient has come to me for. Okay, if she's come to me for menstrual irregularity and getting the periods right, I tell them, okay, generally these young girls, we put them on the combined oral contraceptive pill. We tell them that, okay, this will help you a little bit after about 6 7 months of continuous use of decreasing the new hair which will grow, but the present hair which you have, or the present thing which you have, that you will need treatment. So you can go for laser or whatever. So that is there. But you have to make them very, because when you put them on OCC, they want to see results fast, but you have to tell them only 7 or 8 months of continuous use, then the skin effects will come up, like the skin will clear up, the acne will go. But till that time, whatever additional treatment you need, you need to do that anyway with your skin specialist, or the way it is. And that's what I tell them to
Perfect.
do. Be a
So,
little patient and continue the treatment, because
so
that is what.
I think your point was very clear that depending on what the patient has come to you for, and depending on what they want at that current scenario, we need to take it forward from there. So that is a very perfect and appropriate thing that we can do or we can tell them, sir. Wonderful. So next, of course, we there are a lot of complications, and one of the complication that you talked about is infertility. So infertility and PCOS go hand in hand. As per your clinical practice, clinical scenario, I'm sure you see a lot of PCO girls with infertility, etc. So, what do you find? Like most of them end up like is it easy to probably after a little bit of weight loss, etc. for them to conceive with oral ovulagens, or sometimes do you need to even go for ART? And what do you and like, how well do they take it when you tell them that probably you need IVF?
Oh, they take it very well. They take it very well. It's only the cost factor which deters some girls, but in general, IVF is very well accepted today. And I'll tell you one case which I had now, and severe PCOS, and not responding. See, first thing is, of course, you to tell them, try and get your weight a little bit low and all. And many of them respond after they lose
Wait.
7 or 8 kgs, and they respond very well to even oral stimulating agents. But if a patient is not responding to that, and then the next option which you say is anyway you want to induce ovulation by gonadotropins, then I gave this girl the option that look, if you want gonadotropins, if you want, we can straight away go ahead, because once you use gonadotropins, you are not sure what sort of a response you will get. You may get hyperstimulation and you may get all those other problems. So then instead of doing an emergency sort of putting her on the IVF cycle, IVF is a good option for PCOS girls, because if sometimes you have these big honeycomb ovaries or big ovaries with with multiple eggs, and they don't respond to either letrozole, or they don't respond to metformin plus letrozole, then you have no other option but to use gonadotropins. You
Sir.
can use 1 or 2 cycles of low dose gonadotropins and see if they produce an egg and rupture. It's good if they do that. So then you can even offer them an IUI or planned relations. But if that doesn't help and you have to go to a higher dose of gonadotropins with PCOS ovaries, then we have to offer them ART. And once they know the struggle which they have gone through, like cycles of follicular monitoring where they're not getting a response, then they're quite okay for ART also. Though ART
Perfect.
also, you have to counsel them about all the hyperstimulation and freeze
Yeah.
all, and it'll take time, and but I think it's a decent option to offer them.
Perfect. So I think, as you said, I think it's important for us to counsel them for ART. They take it quite well, but of course, we do not want to take a risk, and we probably will go for a freeze-all cycle in which we do not want to expose them to OHSs or something. Perfect, sir. So I think infertility being the most common complication, I think it's well addressed that we will look for oral ovulogens, but most of the times, if it doesn't work out, we might have to go to our ART, take the sought the
Yes.
help of.
Many of your mild PCOS or even moderate sort of PCOS with weight loss and all, many of them do respond. It's not that
Exactly.
most of them
No,
requires
obviously, yeah,
ART. This I'm talking about severe PCOS, large ovaries,
not
multiple.
responding.
Yeah, so then sometimes you can't help it. But if you
Perfect.
use gonadotropins in this girls, it's better to do that. But mild PCOS and all, you can definitely.
Yes. I think weight loss, as I said in the beginning, I think as you were also mentioning, is one of the primary things that we can do. It doesn't work out, yes, then look for other
So
options as well.
what
Perfect.
I had this patient who came to me and says, I don't believe it. I don't believe it. She was a PCOS girl whom we had counseled for weight loss and all. And then
Mhm.
she took a year off and she lost her weight. And she came back with a positive urine regress. How can it be positive? PCOS patients don't conceive easily. Now, how is it possible? I said, it happens because you've lost weight and you've done the right things and you've done the right things. So you've ovulated and you've conceived. So that is how it is. Sometimes even the girls have this in their mind that always there's going to be a problem in conception.
होना नहीं था कैसे हो गया. Correct.
हाँ तुमने तो बोला था मुश्किल होएगा so
Correct. Correct. Perfect, sir.
no lifestyle. I mean, I've really come to believe, because so many patients I've seen, the moment they lose, like obese patients who were 85 90 kgs, who have lost 10 kgs and all, they come back feeling so good themselves, and then they ovulate and they conceive.
Perfect. Perfect, sir. So now that you have put in all your efforts, the patient has put in efforts, she lost weight, she conceived. Now, what are the complications that you see in pregnancy that you would like to address or would like to tell everyone, and how do you go about in probably decreasing
So
the complications in pregnancy?
So one point, Priyankur, before we go to getting her pregnant, is pre-conception counseling is very important. Make sure that these PCOS girls, before they get pregnant, they come to you for investigations and advice. And what you need to do is basically their OGTT, and make sure that they have not become sugar intolerant. Because I've had PCOS girls whom we said, okay, 6.1, lose some weight, get going, and they come after 2 years when they are pregnant, and then HbA1c is around 7 or 8 or 9. So, and then they don't even realize they've become diabetics. So a proper preconceptional evaluation of their sugars, of their thyroid, all that is very important in all PCOS girls when they conceive, because if their HbA1c is higher than 6.5 and it goes to around 7 or 8, or then there's a 15 to 20% chance this baby could have a chromosomal defect and a structural defect when it's developing. And this is the time when they don't even realize, they are pregnant, 6 weeks, 7 weeks pregnant, and all the damage has already occurred. And if that HbA1c is high, this could affect the fetus. Though, if the HbA1c is even high, you do not advise a termination, because today we've got enough techniques to pick up these problems, like the 11 to 13 week scan today can pick up 60 to 70% of all malformations. And if you couple it with a 18 to 20-week scan, almost 90% of all abnormalities can be picked up. So basically, we tell them that, okay, you continue, but get the sugars under control. So if your HbA1c is less than 6.5, hardly any chances of this girl having any congenital malformations. But if it is higher than that, well, the chances of having a congenital malformation increase, and the malformations of the skull or the spine are common, but they can be picked up by sonography. So do not encourage a termination.
Termination.
Find out. Now, when you find out, also, what one important point which we all forget: if she's a diabetic and not regular PCOS girls, if she's a diabetic already when she's become pregnant and HbA1c is high, please mention on that double marker form which you send for your at the 11 to 13 week scan for screening for Down syndrome, that she's a diabetic, because the PAPE value changes, and they need to make a correction according to the FMF, and give you a report accordingly. So that is one thing which you have to remember. But basically, in general, most of these girls, they are prone for GDM. PCOS patients are more prone for GDM. They are more prone for hypertensive disease in pregnancy. So what you need to do is screen for the sugars and screen for the blood pressure. So sugars, I've told you about the first trimester screening, and what we normally do now is the DIPSI test, where we give 75 grams of glucose irrespective of fasting, and after 2 hours we see if the level is more than 140 or it is less than 140. If it is more than 140, she is labeled as a gestational diabetic. And if you pick up a gestational diabetic in the first trimester, that is the role of time of doing HbA1c, because you want to know what is the sugar control like in the first 3 months or in the periconceptional period. So it's important to uh, do the sugar test at the first contact, preferably in the first trimester. And if that is normal, repeat it at 24 to 28 weeks, because that is the time when hormones of pregnancy will come into play. And that is the time when a normal glucose tolerant woman can become glucose intolerant. And we have seen so many girls happening that it becomes intolerant at 26 to 23 weeks, especially PCOS girls, because they are prone to get GDA. Now, the thing is that the moment you develop this, you get this report, their first reaction is, अरे no, no, कल मैंने कुछ केक खाया था इसके लिए बढ़ गया and all. So you have to explain to them very properly. And the explanation is more towards what we know now, that if this high blood glucose in pregnancy is toxic to the baby, so this high blood glucose will make the baby put on more weight, will make the liker more, can have other problems in growth. But the worst thing is it programs the baby's pancreas so that this baby will become diabetic in future. So once you tell the woman this point, that this baby, if you don't control your sugar, this baby will become diabetic in future, they will follow your advice to the last letter. So, so you have to tell them, depending upon the sugar level which you have got, if it is mild, then she can first try to be controlled on diet and exercise only. And then otherwise, we add either oral or hypoglycemic agents or start insulin, depending on the level of the sugar. But they have to be prepared for that. At the same time, please screen for the blood pressure, because they are known to become hypertensives in pregnancy. So because the incidence of hypertension in pregnancy is also very high in PCOS girls.
Perfect. Perfect, sir. Very well pointed out, very well addressed the points up. So I think PCOS, yes, and of course, I think after the delivery, of course, some PCOS babies, as you said, with diabetes, etc., there's a chance of premature delivery. There's a chance of hyperglycemia, etc. And as you mentioned about the fetal origin of adult disease, etc. And so they might end up in the NICU care, etc. And that is also things that we talk about.
Yeah,
So
so
before
there
we
are
come,
immediate problems and later problems which you have to
yes,
allude to the women. And generally, most of the PCOS women who becomes a JDM, most of them are controlled well on diet and exercise. So you to tell them your fasting should be 90 and post lunch should be 120. So one very good sentence which one of my friends Sunil Gupta from Nagpur says is on how good the sugar control should be. The sugar control should be so good that the fetus in utero should not realize that the mother has got diabetes.
okay, yes, that's a wonderful, wonderful statement, a wonderful way
Very
to,
nice way to put it, I would say.
yes, yes. So now we have talked about like most of it. We will be looking at few long-term sequelae and metabolic disorders, etc. But before we come to that, you were talking about PCOS in men. I would request you to highlight a little bit about PCOS in men.
Don't ask me to highlight about PCOS and men. It is a Some men have early alopecia, they lose their hair early and all. So, the question is whether something is happening in men where hyperandrogenism is occurring. And that is a whole concept which has come up, but it is yet not a fully standardized concept or something which we need to really address that doing this will help this. It is just a concept that it is like something what we see in women, is it happening in men? That's all. And that is, I mean, she has got a full lecture on it. So you should ask Dr. Durusha about it.
Absolutely. Perfect, sir. Sure. So, sir, I would next, before we conclude this entire session, talk a little bit about the sequelae. You did talk to us about the diabetes mellitus part of it. Could you just highlight a little bit about dyslipidemia and hypertension? And PCOS is very well linked to it. So, like, what are the
Yes.
chances and how do you, sir?
No, dyslipidemia, like when this girl grows older and into perimenopausal age, one has to take care of the lipids because today we are seeing so many women having cardiac problems. And it is something because we used to feel that women are safe as long as they have the estrogen, and it'll save them from the cardiac issues, but it is not so because today dyslipidemia is happening so high in all these girls, and they are more prone to cardiovascular disease in future. So one has to take care of that. And there could be a role of statins and all, but we leave it to the physicians. If we find a abnormal lipid profile, we leave it to the physicians, and maybe statins have a good role to play in women also.
Perfect.
And
So I
hypertension
think
is something which one needs to screen for anyway, and maybe in all Indians because we all are prone to hypertension.
perfect, sir. So, what is of course, you talked about endometrial carcinoma, endometrial hyperplasia, etc., that is attached, that is associated with PCO. So, would you like to highlight a little bit about the same as well?
So we have a lot of women coming in the perimenopausal age and all, where they have irregular bleeding. They don't bleed for 2 3 months, then they suddenly have heavy bleeding. So what you try to do is give them progesterones, control the bleeding, and at that time, please remember if this woman is maybe a PCOS girl who has become a diabetic and has a thick endometrial lining. What I prefer to do is try and control it with hormones if the lining is around 10 to 12 or maximum 12. But if it is more than them, I would seriously advise them undergo a DNC to get the histopath of the endometrium to rule out any changes which could be occurring there. And at the same time, I counsel them, why don't you put in something like a LNG IUCD so that the long-term progesterone which is released keeps your lining thin and you don't fall into the same problem again. So it's a good idea to insert that when if you're doing a DNC for such women at that time, so that it gives them a proper solution. And women are so happy. Even many of the young girls who want contraception, once I put them on this, they say, "Oh, it's great because we don't get our periods, or periods are very scanty. Our lifestyle is not interrupted." And so many perimenopausal women who have undergone this treatment, it's good. And another thing which you should remember is there are some women who will have an adenomyotic uterus or will have fibroids, etc. Or they they feel that this is not well. In those women, then I say that you try DMPA, a Depo-Provera injection or a DMPA injection once in 3 months sort of solves your problem because it keeps the lining thin. That is what you are interested in, keeping that lining thin so it doesn't become hyperplastic and have problems. So it's a good idea to try both these methods before we say, okay, your bleeding is not under control. And like many people just would opt for a hysterectomy or advise an hysterectomy. But if the uterus is more or less okay, it is better to give these sort of treatments. And I am a very good. I use DMPA very freely in my practice, and women are very happy with it. Once in 3 months injection, take it for a couple of years. If the bleeding is under control, if they reach menopause, it is fine. So because it is important in those women, especially who are in the 40s or 42, 43, they can take it for a couple of years. Younger women also take it and then they can stop and see, but generally it reoccurs. So either this or a LNG
LNG.
IUCD is important.
Perfect. Perfect, sir. So, as you said, I think it's important for us to screen. We need to be aware of the fact that PCOS could predispose to hyperplasias. Screen is something that we definitely need to do. So there is a bit of talk that's happening about PCO and ovarian cancers. So, do you feel that this PCO, which is because of which there is constant probably anovulation that is happening, because of this anovulation, probably sometimes the ovaries can go into a bit of ovarian cancer sort of a thing. So, do you feel that that is something that needs to be really be worried about, or do we need to address it routinely in our practice?
I'm sorry, I will not be able to answer that. I think you should give me more information because
I,
I'm
I was
not
just
versed
I
with
was
this.
just reading through it, and they say that probably because in PCO probably because of constant anovulation, because of the follicles, it's not the ovaries are not ovulating on a routine basis. So because of that, they say probably we have to just keep it in mind, especially in case of PCO when it ends up with probably sometimes with an endometriotic cyst or something of that sort, which sometimes happens. So in those cases, we have to keep that in mind, and we shouldn't just think it's endometriotic cyst. We do not need to rule out an ovarian CA. Get a CA 125, etc. done, rule out everything. And if you feel everything is all right, you can be, okay, rest assured that okay, there's nothing. But we need to keep that component in mind as well, is what I was reading about. So I wanted your opinion. But I think that's something
I'm
that we
not
can.
really very much aware of it
Okay,
as yet.
sure, sir, sure, sir. But then you have like already highlighted wonderfully about like the everything about PCO. So we are at the fag end, so we've got another 5 minutes before we end this session. So I would, of course, now before we end, would like to ask you for your take-home message for everyone, especially in perspective to your counseling points, which will help everyone in their day-to-day practice.
Yeah, I think we as doctors have to, like when a couple comes to me and I'm counseling the guy, counseling the woman, and if this husband has got a paunch, I do turn to him and tell him that, look, what are you doing about it, sir? Because even today I had this patient who is diabetic, and I don't know why all diabetics take it very lightly, the sugars. Like I asked him what is the fasting, and fasting is around 140 PL,
Mhm.
it goes to around 220 and all. I said,
They're happy with it.
you're telling me as if you're proud of it. So then I told him that, listen, diabetes is a very silent disease, and you will not even know when it affects your kidneys and heart and your eyes and all. And you have to look at the couple, concerned with the women. So the simple message which I gave all these both the couples is, please inculcate some amount of physical activity in your daily routine. It doesn't work otherwise. You have to make it a habit, and if you do it for at least 30-40 days, then it will become a habit. You need to be physically active for at least, depending on the age and the BMI, etc., at least for 30 to 40 minutes of good physical activity every day. And you have to be very aware of what you are eating. Meet a dietitian if you want, or today there's so much of gyan available with all the reels, what to eat, what not to eat. So you have to choose and do that. you have to you have to do something to get yourself into that proper BMI, to restrict your weight, and to get on track. And so one simple thing for adolescent, of course, is and I'm surprised with the way people now, because so many people tell me that all the youngsters now, they simply order and that food is there on the table. So they don't even have to think about what they are making or eating or whatever. Whatever they wish for, they can order on the phone and they get it within 10 minutes, blink it or whatever it is. So, so, So this is where the problem is. You have to be aware of what you eat, and you have to be physically active every day and do something so that you can do it. So that is one thing. If you aim at that, the most of your health issues will resolve, and it'll help you. That is one thing which I tell all the PCOS girls and all the other obese girls which come. But remember one more thing now, obesity is something which, like, if you're 110, 120 kgs, it is not easy to lose weight. So nowadays we are getting all these anti-obesity drugs. Use them, get it. I've had patients whom I said, "Arey, get a at that time gastric bypass or whatever done, get rid of some amount of weight and then get on track." So very obese patients, where you have to sometimes help them by all these methods, either the drugs which are coming in, or gastric surgery or bypass or whatever, and help them to lose weight and get them on track. Because PCOS girls, especially obese, very obese ones, they will really benefit by doing any of these procedures, getting to the BMI and then giving you a result.
Perfect. So, and since you talked about bypass, since you talked about the medicine that's coming, so what's your routine take in your practice with the GLP-1s? Do you use the tirzepatide, that is that Munjaro that's coming now? People are talking a lot about it. They're saying that losing weight with that is helping. Any experiences with any of these medications
No,
currently?
I personally don't have an experience, because honestly I'm a little scared, pancreatitis and all the side effects. And I said, अरे वो इधर आके मेरे को बोलेगी उल्टी होता है तो मैं क्या करेगा? तो what am I going to tell them more? So initially I'm sending it to my endocrinologist to help me for that. But I think gradually, Priyanka, we all gynecologists will have to come to it, and most of them have started prescribing also. And so we will have to get into it, and we'll have to learn, how to pick up the side effects or to the bad effects. But in general, I think they really help. There are some patients whom it doesn't suit them, but I think it generally helps. We will have to
Perfect. I
get
think
onto it, and we as Gynacs will also have to start prescribing it and not leave it only to the endocrinologist. See, here in Bombay, we have the facility of the endocrinologist just next door, and also it is okay. We say, "Arey, udhar jaake le lo." But in
perfect.
generally, I
Makes
think
sense.
we have to get onto it.
Maybe in a smaller place. So that's why in Siliguri, we have started using it. I mean, it's sometimes because for me personally, people who know me, they know I'm a little on the plumpier side. And because of that, it's difficult to counsel a patient when I tell them, you need to lose weight, and they sort of give me a look, okay, you are telling me to lose weight, but what about you, sort of a thing. But then, yes, it
You're
definitely
not
is.
that plump, yeah. You're more or less in your BMI.
So,
You're more or less in your BMI.
yeah, man. A little bit more, yes. But then that's the thing, sir. So that's why it's nice when, and so with this medication that's coming now, so it's helping. It's not that it's not helping, but the thing is, yes, the bottom line stays the same. You can't take the medicine and do whatever you want. You have to
Yes.
control your diet. You have to do your exercises. This medicine is an add-on to probably help you in losing some weight, but it's not the ultimate thing that will make you lose weight. It's still the bottom line is diet and exercise. You do it, you get better with it. So, sir, thank you so much for all your insights. I think I will probably end by saying that, it's very important for us to recognize it early, as you said, to sustain the lifestyle changes that you mentioned about, and probably look at a multidisciplinary approach, which sometimes could involve a psychologist, sometimes maybe a cosmetic dermatologist, or sometimes even in an endocrinologist setup, sort of a thing, as you said, and
And
sometimes
a
as simple
dietitian.
as, sir?
And a dietitian.
Dietitian, very important. Dietitian who could help, in probably helping them in losing a bit of weight, and probably sometimes to do with a little bit of, some physical trainer who could help them in some bit of activities, gym, personal trainers, etc., that people do. And I somehow, some of my patients, they tell me, doctor, you have told me to lose weight. I sort of go out walking every day in the morning and etc. But then ultimately, this morning walks that they do are usually those early morning kitty parties that they do on the road, talk to each other, smile, laugh, come
So,
back at
so,
home.
I tell my patients walking is an activity. It is not an exercise. And walking is more for, people of our age group where you can't run. For them, I tell them that, listen, you start walking, yes, but start walking fast and gradually go on to a jog, because otherwise it's not going to help you. So
Absolutely.
I tell them very clearly, you need to do some amount of strenuous exercise, 30 to 40 minutes in a day, whether you do it in a gym or you do this. And in addition, 60% is diet control. 60%
Absolutely, sir. So I think you need to sweat it out, otherwise it doesn't help. There's no point of doing a kahani early in the morning, going for a walk and coming back and saying I've done my exercise, but nothing is getting lost.
Yes.
So my sir Vinit sir always used to tell you have to, if you gain weight when you're putting in too much and you're not losing too much. So it's
Yes.
ultimately it's that. So you shut your mouth, keep do your exercise, you will get better on it. So thank you so much once again for all the insights you have put in. Thank you for giving this time, and I'm sure it was a session that people will definitely help them in their day-to-day practice. Thank you once again, sir, for being
Thank you,
here. Thank you
Priyankar,
so
and thank
much.
you, Foxy and Sunita, for this opportunity. Thank you very much,
Thank
and
you so much, sir.
very well brought out things, Priyankar. All the
Thank you
best.
so much, sir. Thank you, sir. Thank you for being there. Thank you.